Welcome, knowledge seekers and professionals, to the channel of the Swiss Journal of Radiology and Nuclear Medicine. A quick heads up, the following audio does not include any images, tables, or other additional information. If you're interested in the following paper, please visit our website listed in the caption below. Now, let's get started. Today, we're going to dive into the scientific publication with the title Bilateral Ovarian Goiter, Case Report and Review of the Literature by Asha Sadoki, Sofia Shkiker, and Nadia Ismaili Alawi. Introduction. Ovarian goiter primarily represents an anatomopathological entity characterized by the presence of differentiated thyroid tissue within the ovary, typically categorized as a mature monodermal teratoma. Consequently, the spectrum of anatomopathological and functional manifestations of ovarian goiters mirrors that of thyroid pathology itself, encompassing benign lesions, potentially malignant lesions, instances of metastasis, and the occurrence of hypothyroidism. The majority of ovarian goiter cases are benign and typically unilateral, with only 5% to 10% exhibiting malignant features. Objective. This report presents a case of bilateral ovarian goiter, accompanied by an analysis of clinical and biological parameters, morphological and isotopic imaging characteristics, and anatomopathological aspects. Additionally, various management methods are discussed, along with a comprehensive review of the existing literature. Patient and observation. The patient, aged 38, was biparous, hypertensive, and diabetic, managed with dietary measures, and had no significant personal or family history of thyroid disorders. In 2014, she presented with pelvic pain, leading to consultation with a gynecologist. Subsequent evaluation revealed an ovarian mass, prompting left adnexectomy and resection of a right ovarian cyst. Pathological examination confirmed left ovarian goiter and a right dermoid cyst, both benign. 3 years later, the patient developed Graves' disease, diagnosed through TSH receptor antibody testing and thyroid scintigraphy. Following a relapse, she underwent radioiodine therapy supplemented with levothyroxine. In 2018, she experienced intermittent right hypochondrial pain and spontaneous hemoptysis, prompting a thoraco-abdominal pelvic scan in 2021. Imaging revealed multiple nodular and micronodular pulmonary parenchymal lesions, hypervascular liver nodules, and a pelvic cyst. A CT-guided lung biopsy confirmed metastatic thyroid carcinoma, while pelvic MRI suggested a suspicious right ovarian cyst. Given the clinical history, a right adnexectomy was performed, revealing thyroid tissue suggestive of secondary thyroid carcinoma. Subsequently, total thyroidectomy with bilateral lymph node dissection was performed. Histopathological examination indicated microvesicular adenoma and dystrophic thyroid parenchyma without malignancy. Post-surgery, elevated thyroglobulin levels and positive anti-thyroglobulin antibodies were noted. 4 months later, high-dose radioiodine therapy was administered after thyrogen stimulation. Peritherapeutic evaluation showed decreased thyroglobulin levels and negative antithyroglobulin. Imaging revealed iodine uptake in pulmonary and hepatic lesions and a pelvic mass. A second radioiodine therapy was administered after 6 months, showing regression of pulmonary and hepatic lesions on imaging. Follow-up MRI revealed no abnormalities. 9 months later, the patient received a third radioiodine therapy after L-thyroxine withdrawal. Post-therapy imaging demonstrated regression of lesions. 1 year later, the patient underwent a follow-up assessment to evaluate treatment efficacy, with peritherapeutic measurements showing TSH suppression at 232.05, thyroglobulin at 0.35, and negative antithyroglobulin antibodies at 7.30. Scintigraphic imaging displayed a uniform distribution of radioactivity. The patient has been declared cured and is currently undergoing regular biological monitoring while receiving a reduced dosage of levothyroxine, aiming to achieve a target TSH suppression level below zero point 0.1. Discussion. The term teratoma encompasses a group of intricate tumors originating from pluripotent germ cells, derived from embryonic layers. These tumors typically consist of varying proportions of three embryonic tissue types: ectodermal tissue, derived from the skin and nervous system; mesodermal tissue, derived from fat, bone, and cartilage; less frequently, endodermal tissue, derived from gastrointestinal and bronchial tissue. Teratomas are among the most common tumors in young women, predominantly found in the ovaries, but occasionally observed in locations such as the brain, mediastinum, or retroperitoneum. While teratomas may sometimes occur bilaterally, they are typically unilateral. There are three main types of teratomas. Mature teratomas, also known as dermoid cysts, are benign, slow-growing tumors. Immature teratomas are rare malignant tumors that grow rapidly and exhibit varying degrees of aggressiveness, as determined by histopathological examination. Monodermal teratomas are much less common. Ovarian goiters, first described by von Calden in 1895 and Gottschalk in 1899, are single-tissue teratomas predominantly composed or exclusively of thyroid tissue. Thyroid tissue within these tumors can be normal, hyperplastic, or rarely neoplastic, with the latter referred to as struma ovariae. While most ovarian goiters are benign, malignant transformation, known as malignant ovarian goiter, is exceedingly rare, occurring in less than 1% of cases, typically in individuals around 50 years of age with extremes of 26 and 77 years. Diagnosis of ovarian goiters is often incidental, although symptoms such as abdominopelvic mass, acute abdominal pain, hypothyroidism, abnormal uterine bleeding, ascites, or features of Meigs syndrome may prompt evaluation. Ovarian goiter is most often diagnosed during a routine examination or in the presence of symptoms, essentially an abdominopelvic mass in 78% of cases, acute abdominal pain in 22% of cases, and more rarely, signs of hypothyroidism and abnormal uterine bleeding. Ascites occurs in a third of cases, and some patients may show features of Meigs syndrome. The literature reports that if a mass was present, it often involved the left ovary. Occasionally, a secretory ovarian goiter may cause the hypothalamic pituitary axis to rest, with a risk of postoperative hypothyroidism. A few cases of ovarian goiter with manifestations of autoimmunity, such as Hashimoto's disease or Graves' disease, have been reported. Imaging modalities such as ultrasound, CT, and MRI can aid in the differentiation and diagnosis of ovarian teratomas. Radiological characteristics described by Kim and others include a complex multilobulated mass with thickened septa, multiple cysts of varying signal intensity, and solid components. Enhancement of solid portions following gadolinium injection corresponds to thyroid tissue and stroma with abundant vascularization and fibrous tissue. In terms of pathological diagnosis, Devaney and others concluded that the criteria for diagnosing malignant ovarian goiters should align with those used for thyroid carcinoma. Only tumors exhibiting cytological features indicative of malignancy, such as irregular, overlapping, and ground glass cell nuclei, intense mitotic activity, or signs of vascular invasion, should be classified as truly malignant and at risk of metastasis. Immunostaining for thyroglobulin serves to confirm the thyroid nature of the cellular component in poorly differentiated forms and aids diagnosis in approximately 16% of cases. The primary goal is to decrease disease incidence and prevent unnecessary treatments. Metastatic dissemination is rare, occurring in approximately 5% of cases, either through regional lymphatic routes to the pelvic and periaortic lymph nodes or through direct extension to adjacent structures such as the omentum, peritoneal cavity, contralateral ovary, or hematogenously to distant sites including bone, lungs, liver, and brain. DeSimone and others advocate for total thyroidectomy, which not only enables exclusion of a primary thyroid tumor metastasizing to the ovary, but also facilitates systematic additional treatment with radioactive iodine and enhances subsequent monitoring. Their therapeutic line of action is supported by findings from the literature, indicating that all patients who received additional treatment with iodine 131 achieved remission, whereas 50% of patients treated with ovarian surgery alone experienced recurrence. Additional treatment with ablative doses of iodine 131 after total thyroidectomy is warranted in cases of locoregional tumor extension, distant metastases, or tumor recurrence. The risk of recurrence, challenging to estimate given the limited number of reported series, is approximately 15%. Therefore, ongoing monitoring is recommended even for benign goiters due to the difficulty in definitively confirming benignity. This surveillance aims to detect local or metastatic tumor recurrence and relies on clinical monitoring, measurement of circulating thyroglobulin after TSH stimulation, and increasingly, PET-CT imaging. Conclusion: malignant ovarian goiter represents a rare ovarian tumor characterized by nonspecific clinical symptoms. Diagnosis of these tumors relies on histological examination, often presenting challenges, particularly in well-differentiated forms. Treatment typically involves radical and extensive surgery for elderly patients, while young patients with localized tumors may benefit from conservative approaches. Although late recurrence with malignant transformation is uncommon, it remains a possibility, underscoring the importance of long-term monitoring. Given the rarity of malignant ovarian goiters, their management necessitates optimized coordination among multidisciplinary teams. Currently, radiotherapy is recommended in cases of residual tumor, recurrence, or metastasis. We have come to an end. Thank you for listening in, and until very soon with more interesting publications. If you want to share your own paper in our journal, feel free to contact our team. We are looking forward to hearing from you. Don't forget to like and share if you enjoyed this content. Click the subscribe button so that you don't miss out on future publications from the Swiss Journal of Radiology and Nuclear Medicine. Until next time.